it gives me great pleasure to introduce to you Dr. Erich Sturgis, who's going to talk to you about underappreciated cancers caused by HPV. You've heard a lot during this summit about reframing the discussion around HPV vaccine from one about sex and sexually transmitted infections to that of cancer prevention. I think that Jill gave you some wonderful information to help you do that, and I think that Dr. Sturgis is going to do the same. Dr. Sturgis received a Bachelor of Science degree in biochemistry from Louisiana State University and later attended Georgetown University School of Medicine in Washington. He completed a residency in otolaryngology, head and neck surgery at Tulane University, and completed a fellowship in Amsterdam. He then completed a 2-year research fellowship in molecular epidemiology of head and neck cancer in the departments of epidemiology and neck surgery at the University of Texas MD Anderson Cancer Center. He completed a Master of Public Health degree at the University of Texas Health Science Center at Houston School of Public Health in 2004 and currently works at MD Anderson. His principal research interests are human papillomavirus and molecular epidemiology of carcinomas of the head and neck region, with over 200 peer-reviewed publications and over 40 invited reviews and book chapters. Please join me in welcoming Dr. Sturgis.
All right, well, thank y'all for having me, and excited to be here and talk about oropharynx cancer principally, but also I will mention some of the other HPV-related cancers. And just to say that we have a whole group of clinicians across the disease sites that we see HPV-related cancers that are very committed to the idea of getting our kids vaccinated and trying to prevent these diseases. I don't have any conflicts of interest to discuss. I'm going to speak first to the epidemiology of these diseases, and then we'll talk about some of the clinical presentation and implications of HPV-related oropharynx cancer. So just to give you an idea of what I do as far as taking care of different cancers, I treat cancers of the skin, melanoma, and more common skin cancers, cancers of salivary gland, thyroid gland, and sarcomas. But traditionally a head and neck surgeon treats cancers of the mouth, the voice box, the throat. And historically, these have overwhelmingly been caused by tobacco and alcohol. But over the past 20 years, we've seen a shift in our patient population to one that's more principally located of the oropharynx, the throat, and related to the virus HPV. So to get everyone on the right page anatomically, when we talk about head and neck cancer that we're talking about today, I'm talking about the back of the tongue, the lingual tonsil, the base of tongue, the throat part of the tongue, the part of the tongue you can't see when you just open your mouth. I'm not talking about cancers of the mouth. I'm not talking about cancers of the voice box. I'm talking about the base of tongue and then also the tonsils. The tonsils are on the side of the throat towards the back of your throat. And those are the sites that are related to HPV, at least in the head and neck. Now, to get us a little repetitive to what Jill had spoken about earlier today, I'm going to talk about genital HPV infection. Most males and females will be infected at some point in their life. About 80 million Americans will have an infection if we just test it at any one point in time. About 14 million new infections each year in the United States. It's the most common sexually transmitted disease, though really the term disease doesn't really hold water because most of the time people are asymptomatic when they have an HPV infection and they clear that HPV infection. And it's most common, as Jill said earlier, in the teens and in the 20s. Looking at international data on women having normal cytology, sort of a normal pap smear, but is HPV detectable. And if we look at North America shown here, we can see highest rates in the 20s and younger, consistent with what we just talked about, and prevalence rates dropping for HPV genital infection as women get older. That's also true in Europe, but if we look at Latin and Central America, we see these higher rates persisting in women as they get older, and similarly in Africa persisting as they get older. How about oral infection? This is probably the best study to date about oral infection as a population level data. This comes from the United States, about 5,500 men and women across the country, all different ages from 14 to almost 70. And we can see that prevalence of oral HPV being detected goes up as the number of sexual partners that a person reports goes up. So the prevalence rate goes up, and this is particularly true with the number of oral sex partners going up with the increasing prevalence. At any one point in time, shows this is men and the age at the bottom here. So HPV prevalence in the mouth and throat is somewhere between 10 and 15% of men at any one point in time. You can detect HPV there. In women, it's lower, down around 5% or even lower. This lower curve here shows high-risk types of HPV, in other words, the types associated with cancer, and that rate is around 5% at any one point in time. U.S. adults will have a HPV detected. It's been a few years now since Professor Zurhausen won the Nobel Prize essentially for showing us how HPV causes cervical cancer. Really a tremendous body of work that he provided. And others, and this sort of lays out some of that process. So an individual is exposed to the virus. It's felt that there's probably some sort of break in the surface mucosa, and then the basal layer of the mucosa, this is called the basal layer, these cells get viral infection. The virus gets incorporated into the cell, comes into the cell. It uses the human cell to regenerate itself and to replicate. And then you get shedding of virus in the cervical secretions and mucosa, and then other infections happening. We can assume that this same process is what happens in men, and probably also is what happens in the throat as well. Now, over time, and this can be years of time before a true invasive cancer happens, typically is years of time before an invasive cancer happens, the cells become increasingly abnormal in their appearance. They become what we call dysplastic. They become, in the cervical world, they call it cervical intraepithelial neoplasia, meaning it's not true invasive cancer, it's a pre-cancer. And at some point, it actually gains the ability to invade in and become cancerous. For that to happen, what typically happens is the HPV DNA, a piece of the HPV DNA, gets integrated into the human DNA, and that is what turns on that human cell to ultimately become cancerous. By the time the cancer has happened, most people believe the actual active infection is no longer present. You can detect HPV DNA, but it's typically a small piece of the DNA that's the important piece that's causing cancer. And I can show you that here a little bit more schematically on an individual cell shown here. Virus coming into the cell. The HPV DNA is a circular form of DNA, but it is DNA, not RNA. And a piece of that DNA gets integrated into the human DNA, shown here. And it's an important piece. It's either the E6 region or the E7 region producing these. These are viral proteins that it uses the human cell to produce. Those viral proteins work through various mechanisms to cause cancer. Okay, so the virus, it's not important that the virus would be still around. It's important that this part of the DNA got integrated into the human DNA and then ultimately became cancer. So there's a lot of ifs and chances here to happen. And this mostly happens by chance, but we're starting to understand that these integration of this happens at specific sites in the human DNA that's important, or it's perhaps sites that are susceptible to integration of viral DNA. If a piece of DNA got integrated that wasn't one of these oncogenes, it may not have any effect. And so you can see there's a lot of ifs here, and that's why despite most of us being exposed to HPV, most of us don't develop HPV cancer. Now let's talk about what we call an epidemic of certain HPV-related cancers. So you saw this slide earlier today. This is showing the proportion of HPV-related cancers in men and in women. The blue here represents the oropharynx, so the tonsil and the base of tongue. So about 3/4 of HPV-related cancers in men are of the oropharynx. In women, just over 50% of HPV-related cancers in women are of the cervix. In both men and in women, about 15%, this red pie here, are anal cancers. And in women, another 12%, 15% shown here, the lighter blue, are of the vulva, and only 12% of HPV-related cancers in women are of the oropharynx. And in men, then you have a small slice of the pie that is attributable or is contributed by penile cancers. This shows what's happening in the incidence rates for the different sites. So the line here, if it goes to the left of the line, it means a decreasing incidence. If it goes to the right of the line, an increasing incidence. So this is cervix here. And we can see declining incidence in most ethnic groups shown in the lines across, down here. Declining incidence for cervical cancer across groups of women, and that's significant, shown by the asterisks. It's also true for vaginal cancer, declining incidence. For vulvar cancer, we actually see increasing incidence for vulvar cancer in white and black women. And penile cancer, relatively rare cancer, no significant change in incidence. But if we look at the top two graphs here, anal cancer on the right, we can see across ethnic groups in both men and in women, men in blue, women in gold there, increasing incidence for anal cancer, significant in most ethnic subgroups. For oropharynx cancer, we're seeing increasing incidence for oropharynx cancer, certainly in white men and probably also in white women, but a significant declining incidence at present for black men. Now this slide shows you smoking prevalence in our country. So since the Surgeon General's warning, and this is the 50th anniversary of that warning, one of the most important public health events in our country, declining prevalence of smoking in our country, cigarettes shown in the lighter blue, but actually all types of tobacco declining over that long time period. And we can see from a head and neck surgeon viewpoint, declining incidence rates for voice box cancer, lip, gum, floor of mouth cancer, all declining in incidence. These are cancers that we know are related to smoking and alcohol. You would see similar picture if you were to look at lung cancer as well. But if we look at, and this comes from the SEER registry, the national registry that we use in our country for cancer incidence, if we look at oropharynx cancer, including tonsil cancer, we see since about 1995 increasing incidence of these cancers. And if we look at tongue cancer, and unfortunately the SEER registry mixes oral tongue, which is of the mouth, with base of tongue or lingual tonsil, which is the base of the tongue. But regardless, it's increasing in incidence pretty dramatically since the mid-90s. Is this related to HPV? Well, people have done this in the United States, but this is maybe one of the earlier studies done from Scandinavia, showing that if you go back to the 70s and look at oropharynx cancers, you can find HPV at a pretty low prevalence in those tumors back then, but in more recent years, it's in the higher range of around 70, and now in the more recent studies, approaching 80%. Something that wasn't mentioned in the last study, I want to mention it here, is the vast majority of HPV-related oropharynx cancer is attributable to type 16, which is one of the types covered by the vaccine, and is the #1 type for cervical cancer, though it's only accounts for, I think, about 50% of cervical cancers. A little bit better study looking across populations in our country by various methods for testing HPV. You can see increasing proportions of tumors of the oropharynx having HPV detectable there. So that suggests that there's an increasing proportion that are HPV positive, and suggests that it's a disease that's a change in the type of etiology of this disease. Is this related to some change in behavior? We don't have great data on this, But this is a study from France that shows, yes, we do know that oral sex behaviors have increased over time. From, we had a sexual revolution of the 60s and 70s. We had a AIDS epidemic in the 80s. And so behaviors of oral sexual behaviors, anal sexual behaviors, increasing over time, both in men and in women. And then increase condom use in our country, lower teenage pregnancy rates in more recent years. A perception that oral sex perhaps is a safer sex is also something that's possibly behind what we're seeing now as an epidemic in these cancers. On the left, it shows women. Incidence for vulvar cancer increasing here. Anal cancer in women increasing. Vaginal cancer been remaining a relatively rare cancer. The same is true for penile cancer, a relatively rare cancer. No significant trends. But in men, also as in women, increasing incidence for anal cancer. At MD Anderson, when I started in the mid-90s, we were having about 200 oropharynx cancers a year, and now we're approaching 600 a year. Our cervical cancer numbers have been, and these are newly diagnosed patients, our cervical cancer numbers have been relatively stable during that time, but we are seeing increasing numbers of vulvar and anal cancer as well. Internationally, this is shown colored by cancer mortality, and it's just women. So internationally, cervical cancer accounts for the #1 cause of cancer death among women in most of Africa and many countries in Central South America, as well as some other countries throughout the developing world. I can tell you what this doesn't show is that in countries that account for a huge portion of the world's population, like India and some other countries in Central South America, cervical cancer is very high up there, if not second, third in cancer mortality for women. So HPV cancers, while I mentioned are declining in women in the United States for cervical cancer, in the world they remain a major, major problem. And the reason we've had the benefit in our country and the same in Europe for declining mortality, shown here, is because of this man and others coming up with the Pap test. And so we have now an excellent screening program for cervical cancer, and mortality from cervical cancer has dropped since the 40s, when the 30s and 40s cervical cancer was the top 3 cancers in incidence and in mortality for women. Now it's relatively rare. This slide was also shown in the Jill's presentation, and this is, if you go to their website, the CDC website, I would like to recommend that to you. There's fabulous presentations available that really hit home a lot of the points that you've heard today. But while cervical cancers become relatively rare in our country, HPV-related disease and screening for HPV-related disease is a tremendous problem. So somewhere between 1.5 million cases of early premalignancy, CIN1, almost 300,000 to 400,000 cases of high-grade cervical premalignancy, and then 1 million cases of genital warts. So there's a lot of disease attributable to HPV that we're catching before the advent of cancer. We spend about $7 billion for cervical cancer screening in our country and treatment of these premalignant diseases. This is well over what we spend for treatment of all cervical cancers, combined with all oropharynx cancers, combined with all anal cancers and penile cancers and vulvar vaginal cancers. So we have the resources in our country to screen for this disease, but in most of the developing world, I'm not sure that's really feasible. So a point about vaccination internationally is that it really would have a tremendous impact on international health, particularly for women where cervical cancer is such a problem in the developing world. And we can see where screening programs were able to be instituted in some countries in Latin America, dramatically dropping in incidence rates for cervical cancer. But I'm not sure that model can be adapted to all countries throughout the developing world. Now, we have a problem for our country, Europe as well, about the oropharynx cancer. And while we may get our vaccination rates up, and we hopefully can reach the Australians at 80% and prevent oropharynx cancer, people develop these oropharynx cancer in middle age. So we're looking at least 30 years from when we get up to 80% before we really see an impact on incidence rates. And during that time, what are we going to do? We don't have something where we can screen like we can keep screening for cervical cancer to catch these earlier. So in the cervix, you have something that the cervical mucosa, you can directly inspect, you can directly sample for Pap testing, for HPV testing. For the oropharynx, it looks like this. This is showing the tonsil, but it's very similar for the base of the tongue. It looks like this. The mucosa is a cryptic. There's little pits in there, and these cancers are presumed to start down in these pits. It's not that a pre-malignancy doesn't exist. It probably does. Almost certainly it does. It's just we haven't been able to detect it yet, and we don't have a reliable way to detect it. So that's the dilemma we're facing. Now, these are incidence rates in our country. Blue represents oropharyngeal cancer incidence in men. Yellow in these open boxes is cervical cancer, of course, in women. And we can see in 2010 the incidence rate for oropharynx cancer in men equaled the incidence rates for cervical cancer in women. And this shows the absolute numbers of these cancers, and this is in men, the numbers of... Okay. The answer is? Form of a question.
What is the answer?
So the numbers of cervical cancers are projected to continue to decline, as shown here. But the number of oropharynx cancers, number-wise, should be increasing. And it was around 2010, 2011, that the number of oropharynx cancers equaled the number of cervical cancers. Now, what this doesn't show is that not all oropharynx cancers are HPV or attributable to HPV, but a good 3/4 of them now we can say are attributable to HPV. Demographics. Cervical cancer, this is median age shown with the little circles, is in the 40s for cervical cancers, though some women are diagnosed rather young with cervical cancer. This is due to, of course, screening. Shown here, this is just women. Shown here for oropharynx cancer in blue and anal cancer in purple. Median age for diagnosis in women is about 60. That's typical for head and neck cancer, tobacco-related. This is about 60 for tobacco-related head and neck cancer. And I'll get a little bit to that later. Vulvar cancer, you can see this red line increasing incidence rates as women get older. And the median age is a little bit older, 66 on this graph. And for vaginal cancer, older still, 69 being the median age. This is MD Anderson age at presentation for oropharynx cancer. You see this general decline over time. And the national numbers here for men for HPV-related cancers in the 50s for men for oropharynx cancer, as well as for anal cancer. And then you see penile cancer a little bit older. You see how this curve goes up, similar to that curve of continued rise for vaginal and vulvar cancers in women. We can see that national incidence rates shown here on this curve are principally going up for the middle age, those in their 40s and those in their 50s. For those in their 50s, the increasing incidence for oropharynx cancer is a 5% greater incidence each year over the previous year. I mean, that's a pretty dramatic increase in these recent years shown here. These patients, again, median age at MD Anderson, a little better database that we have going forward, is about 55 now for oropharynx cancer. And smoking, most of these patients reporting either being a former smoker or being a never smoker. Only 20% of our patients with oropharynx cancer now report having been a smoker. This shows incidence trends over time for men. This is just men here on the top graph. White men shown in yellow, black men shown in blue here, Chaturvedi in 2008. The disparity in incidence between black men and white men for oropharynx cancer in the mid-'80s was the highest nationally for any cancer site after prostate cancer. Black men have a much higher incidence of prostate cancer, but after prostate cancer, this was the highest disparity between the two. This is flipped, and we can now see, if you actually go to the SEER website, you can see this. Oropharynx cancer in white men is now a higher incidence than in black men. It's a fascinating thing to have happened in essentially one generation. We see at our institutions, and others have reported this, a higher socioeconomic status of those presenting with HPV-related cancer, particularly those that are without a smoking history, as opposed to the HPV-negative oropharynx cancers, which are traditionally a lower socioeconomic group with heavy alcohol and tobacco use. So for this first part of the talk, just some public health implications or summary point. We are seeing an epidemic in oropharynx and anal cancer, certainly, and possibly vulvar cancer. Without novel screening or treatment of these sites for pre-malignancy, we're looking at least 30 years of an increasing burden of these cancers. The cost of cervical cancer screening is incredibly high. It's probably not applicable to most of the developing world. And if we are to institute, or if we are able to institute a screening program for oropharynx cancer in the future, or even anal cancer in the future, we got to remember it's going to cost some significant money. And then finally, just the demographic point, tends to be that oropharynx cancer are middle-aged white men, typically with higher socioeconomic status and a higher number of partners. Now, these behaviors, though, of course, can change over time, and I'm not saying that somehow white men with higher socioeconomic have a particularly high risk. It's that the behaviors of that population is probably different as we look at different populations. And those behaviors of populations change over time. This just goes to show that back here in the 60s and the 70s, a very high proportion of our patients were currently smoking, and now 61% of our patients, or at least in 2004, 61% of our patients were never smokers or former smokers, and now that's 80% of our patients are never smokers or former smokers. Now, here's a problem we have. Patients that have oropharynx cancer, and this is true whether it's tobacco-related or HPV-related, but particularly for HPV-related oropharynx cancer, they're showing up from the tonsil and the base of the tongue, this part of the throat I pointed to earlier. These sites typically do not give you a symptom. And so usually these people show up not because they felt something in their throat, but because they actually felt the lump in their neck, which is the spread of the cancer to a lymph node. So that's a problem for us as far as trying to get early diagnosis. And usually we can't see where they started, or often we cannot see the actual site where it started just by simply looking. This study just sort of confirms that. Terry Day, a friend of ours in South Carolina, showed that HPV positive patients overwhelmingly show up with a lump in their neck, a neck mass, which is the metastasis. And these typical symptoms that we say are classic signs you need to go see your doctor for head and neck cancer, a sore throat, trouble swallowing, pain when you swallow, pain in the ear, bleeding, ulcer in the throat. That sort of thing is actually not so common in the HPV-related cancer patient, oropharynx cancer patient. So this is the picture. This is a story of someone who had a tobacco-related cancer. They have a big tonsil on one side of their throat. I think we can all see that here. But this is actually pretty normal looking. I know they're not the prettiest looking tonsils, but they look the same on both sides. And that patient, this is that patient's neck. That's why they came in. They were shaving one day and they noticed a lump in the neck. That's the cancer spread to the neck. So once it's already spread to the neck, it's already stage 3, and usually they have more than one lymph node when we actually look on a CAT scan, so they're stage 4 when they show up. 80% of the patients at our institution who show up with HPV-related oropharynx cancer are stage 4. I'm going to skip this slide for time. Our colleagues in Canada, largest cancer center in Canada, this is from Toronto, showed just that the HPV positive patients tended to have a lower T stage. That means the size of the tumor in the throat, and they tended to have a higher number of ends, that means nodes, in the neck. They almost always were of the tonsil or of the base of tongue, and they tended to be a higher grade, meaning under the microscope they looked the differentiation of how it looked. It just looked uglier. It's what we call grade of a tumor. This is from our institution, and basically similar findings in the recent years, 86% being tonsil, base of tongue, usually small tumors, more lymph nodes, and at this point 88% were stage 3 or 4 in that breakdown. How about the prognosis? Well, this is a little bit of good news about the HPV problem in the head and neck area. This is from our national population-based registry, the SEER registry, showing 5-year survival rates by year of diagnosis. Okay? This is voice box cancer, larynx. These are 2 sites within the mouth. And you can see survival rates, unfortunately, have not really changed. Despite better radiation, despite, I think, some better surgical technology, despite better use and more appropriate use of chemotherapy, at a national level, we really haven't seen much change in survival rates for head and neck cancer. We're hoping this will change soon, but for oropharynx cancer, a disease which used to be one of the worst survival rates for head and neck cancer, is now actually the best as far as survival rates for head and neck cancer. And I've just shown it here through SEER. They split up oropharynx into tongue, which includes base of tongue, and oropharynx/tonsil. This is our institution for oropharyngeal cancer. These are survival curves, so months from presentation, and then the proportion still alive. So you'd like to see it at 100%, but it drops down for each one. But we were improving each decade, but we had this dramatic improvement after the mid-90s when this epidemic was presumed to have taken place. So there are 5 studies at least now that are phase 3, multi-institutional clinical trials which show with a standard treatment, patients who are HPV positive do significantly better than patients who are HPV negative, and pretty dramatic improvements in survival. For instance, in this study right here, the survival was 80%, or the chance for dying was 80% lower in the group that was HPV positive. Here's an example. I'll just show one study published in New England Journal that shows, again, survival curves shown here, years from when the study was started. And the high-risk group had pretty poor survival, less than 50% at 5 years. Those were patients overwhelmingly who were HPV negative and a typical head and neck cancer story. The low-risk group were those who were HPV positive and had very little or no smoking exposure. So a cancer that you could say is really driven by the HPV. And then an intermediate group that has actually a tumor that's HPV positive, but also has a history of significant smoking. So a little more complicated picture about what's driving that cancer and potentially some bad actors in there because of the smoking exposure. So again, just to reiterate, they tend to have smaller cancers in the throat, bunch of lymph nodes. They rarely show up with with spread outside the area, which is being shown here as lung metastases. And they rarely show up, they do occasionally, but rarely show up with these really big cancers of the throat. Okay. So from a staging viewpoint, we can see that before 1995, our staging system works very well. It shows that stage 1, 2 patients do better than stage 3, do better than stage 4. But after this sort of HPV problem sort of has taken over, and because the HPV patients do better, our staging system doesn't work because our staging system does not incorporate HPV. So we and others are working to try to update our staging system for this. I'm going to skip this slide for the sake of time and just point to this one. Patients who have an HPV-related cancer have a lower risk to develop second cancers, meaning different cancers later, than our traditional HPV negative head and neck cancer patient. Head and neck cancer patients, as smokers and drinkers, they have exposure to their lungs, to their bladder, other sites in the head and neck. We still have a big problem of curing patients but unfortunately later they develop a lung cancer, and that's what they die from. Despite having stopped smoking, that damage was already done. We don't see that really in the HPV positive group unless they have a significant history of smoking, and it's just shown here on this. They may have different sites, though, of second cancers, and these are relatively rare sites, but we showed an association between oropharyngeal cancer and later development of anal cancer or penile cancer in men, and starting with an anal or genital cancer, later developing tonsil or base of tongue cancer. So that association sort of is logical and makes sense. I'm going to close on prevention and talk about vaccination. We see other diseases, and it was mentioned by Jill earlier about the other diseases related to HPV that are not cancer, say genital warts, recurrent respiratory papillomatosis, the pre-malignant diseases, which are a huge number of diseases in this country that we see. We see them in the head and neck of these benign papillomas that are caused by HPV as well. These vaccines, of course, the Merck's vaccine is Gardasil, protects against 4 types. 6 and 11 are attributable to most of the cases of genital warts, most of the cases of respiratory papillomatosis, and even some of these benign papillomas we see in the head and neck area. And then Cervarix is the bivalent vaccine, types 16 and 18. I'll repeat it again. Most oropharynx cancers that are HPV related are attributable to type 16. So the current vaccines should protect against oropharynx, HPV-related oropharynx cancer. I'm going to skip this because Jill covered this morning, and I just want to mention this. This is a huge study from Scandinavia where they have these incredible population resources and databases, over 1 million individuals in Sweden, and showing that those who got vaccinated as opposed to those who didn't get vaccinated, they're already seeing a drop in the number of genital warts. So that intermediate disease she talked about, there's already evidence showing a benefit. How about oral infection? It's going to take us years to show an effect on oropharyngeal cancer, but how about oral infection? This came from the Costa Rica study, one of the original studies used to get FDA approval for the vaccine, showing that in women in that study that they looked in follow-up to development of a oral HPV, detectable oral infection. They showed that in the those receiving the vaccine, 2,900 versus those receiving the placebo vaccine, a dramatic difference in the prevalence of oral HPV infection. They calculated vaccine efficacy for preventing oral infection at over 90%. In this particular arm of that study, they showed that the vaccine efficacy for preventing cervical infection was actually only 72%. So it should be effective at preventing oropharyngeal cancer. She showed this, Jill showed this earlier. I just want to point to these lower 2 curves. For boys, receiving 1 dose is currently at about 1/3 of boys in our country receiving 1 dose, and only about 1 in 7 boys receiving all 3 doses. We have work to do in Texas. We're not in the dark red, which is the lowest rates, but we're not, at least in 2012, we weren't above the median. And the final thing I want to say is what concerns me most about, not most, but one thing that concerns me is that parents of boys reporting why they did not get their boys vaccinated. The number one reason, and it's almost 1/4 of the parents reporting, the number one reason being that it was not recommended. So the healthcare provider was not recommending it to the parent. And I think this point that Jill made this morning, we need to strongly say that it's recommended. It's not that it's optional, it's recommended. It needs to be given to boys. The others, just like she said, lack of knowledge, you could say really, this is a lack of knowledge of the pediatrician or the family practice or the nurse, whoever. That's a lack of knowledge. So really a lot of these can be wrapped up into that catch-all lack of knowledge, and that's something we can fix. So finally, the HPV epidemic is, I hope I convince you, is happening. It has unique demographics, behavioral, and survival characteristics. The staging system for oropharynx cancer needs modification. Second primaries are less of a problem, and then vaccination is imperative. Thank you.
Thank you for a wonderful presentation. We have quite a bit of time for audience questions. Unfortunately, there are no microphones in this room, so if you have a question, please raise your hand. We'll call on you, and either Dr. Sturgis or I will do our best to repeat your question so that everybody can hear and it's captured on the recording. So right on
Yes, ma'am.
my left.
Why do you think there's an increase in cancer among never smokers, people that have never smoked?
Yeah, so why is there an increase in cancer among those who have never smoked? So I know it seemed that way. I didn't actually show that. I showed that the proportion of patients who never smoked is a higher proportion. Okay, so the problem about this is we don't have great population level data in our country about cancer rates in smokers versus non-smokers at a population level. So I didn't mean to suggest, and please don't take it that way, that non-smokers are at a higher risk for HPV cancer. It actually may be the other way around, because smoking does have immune effects on us, and there's some good data that suggests that smoking is a cofactor in risk for cervical cancer. Okay, it's wrapped up in some complicated things about behaviors, risky behaviors, and we see this in some of our studies. Risky behaviors being more common in smokers than in non-smokers. But so I don't think smoking, at least for oropharynx cancer, we can say somehow prevents HPV-related oropharynx cancer. Certainly doesn't, and there's actually data to suggest it may be has an effect on the immune system that could put people at greater risk.
Are there any other questions? Yes.
Yes, ma'am.
Why isn't there a better test to check the back of the tongue when gentlemen come and get their physicals? Why is it that we haven't developed something so better than what we have now?
So it's mainly an anatomic problem, and so the lining of the base of the tongue and the tonsils, as opposed to the tongue. When you look in the mirror, you can see your tongue. You're like, well, why can't they just look at my tongue? They could see a cancer. Well, that's true. And in India, where oral tongue cancer is very common, not base of tongue, oral tongue, they've shown the benefit of screening for oral cavity cancer. Our country, it's too rare to do that. But for base of tongue, first of all, it's hard to see. You have to look back there with a mirror. Second of all, to properly examine it, most doctors don't do it properly. You have to stick your finger back there and literally choke the person to really palpate that area. And probably most importantly is the lining is cryptic. It has little pits down in there, just like the tonsils. And these cancers are starting down in the base of those crypts where they're hidden, so we can't see them. The cervix is a smooth line, relatively smooth line structure that in a pelvic exam you can see. And even for anal cancers with high resolution anoscopy, they can examine that. We don't yet have that available for us for the oropharynx, and I'm not sure we got an easy solution to this problem. There's some things that many people are trying to study, but I think we're a ways away from actually finding something that's going to work.
Yes, ma'am, on the left.
Early on, you talked about certain DNA sites being more susceptible to integration from HPV.
Right.
Do you know, is there any reason why in certain people that's the case? And I'm also curious as to lifestyle choices and how they affect cancer in general.
So the question is is a general question about susceptibility to HPV-related cancer, and sort of tagging off what we mentioned about certain integration sites within the human DNA. So these are very brand new studies over the past year and a half that show certain integration sites maybe are more susceptible to HPV getting integrated there. That's in the earliest phase of that type of research, so we don't fully understand why. But it makes sense that, for instance, just like everyone who smokes doesn't get lung cancer, there's some genetic component of susceptibility. So someone may be susceptible to the damage of tobacco. Similarly, most of us are exposed to HPV. Why do only, and I say only 35,000 of us diagnosed with HPV-related cancers each year? There's probably some component of our genetic makeup that makes us more susceptible to either DNA integration, certainly maybe chronic infection. Why? If a woman the longer that virus is around, the greater chance you have for it to get integrated. So that work is ongoing in multiple fronts, and with modern genetic testing that's being done, hopefully the key will be unlocked. That would really assist in trying to screen people, understanding who's at really high risk. Your other question had to do with particular behaviors lifestyle behaviors that put people at risk for cancer more generally, or?
Your diet?
Yes. Yeah. Well, certainly there's good studies, epidemiologic studies that support diets that are low in animal fats, higher in fish, green leafy vegetables, fruits, vegetables, those sort of things. Just essentially healthy diets seem to lower people's chance for risk of tobacco-related cancers, of other cancers. This has been shown as well. I'm not sure, and you've kind of piqued my interest in this, I'm not sure about diets have been shown yet to be associated with lower risk for HPV-related cancer, but you could think of reasons why they might. So diets certainly that have certain of those poor diets, people probably tend to have more oxidative damage and they can get more DNA breaks. You could make reasons why there would be a higher likelihood that the viral DNA could get integrated. Yes, ma'am.
Is there any information about the prevalence of HPV and then how much of it would convert to cancer?
So is there any information about the prevalence of HPV and how often it would convert to cancer? Do you mean the oral prevalence or?
Whatever's available, oral or cervical?
Yeah. So prevalence of HPV for cervical is very well known, and there's lots of very sophisticated historical studies done that show, clearance rates. Clearance rates are different for different viral types. We don't have that for the oropharynx. The best study I showed that I'm aware of thus far is that study I showed just simply prevalence, point prevalence, not period prevalence. Point prevalence, and it's for men, it's higher. It's between 10 and 15%. For women, about 5% will have an HPV infection. Most common type was actually type 16 that was detected. We don't know about clearance rates for the oropharynx. Conversion rates are, though, still, at any point in time, 10 to 15% of men have an infection. You can surmise that based on studies in men that oral prevalence is probably similar to cervical prevalence, lifetime prevalence, at 60 to 80%. Not 60 to 80% of men are developing oropharyngeal cancer. So the conversion rate, luckily, is low.
If there are no more questions, Dr. Sturgis, I'd like to present you with a small token of our appreciation.
Thank you.
The next session will begin right at noon downstairs in Ballroom B, where you'll hear about important immunization updates for the state of Texas.